probably one of the best. Great expectations of you, sir. Our next speaker is founded and for 33 years has directed the Alpha-1 program at National Jewish Health in Denver. He has served on the boards of the Alpha-1 Association, Alpha-1 Foundation, AlphaNet, and that one too. And I have to learn that one. He is currently the Executive Vice President and Medical Director of AlphaNet and the Clinical Director of the Alpha-1 Foundation. He holds the current record for the most number of presentations at any one national conference, and I'm joking about it. He probably does. And please welcome Dr. Sandy Sandhaus, who will discuss the health risks to carriers, knowledge gaps, and evidence for and against various treatments for carriers.
Thank you. So I gave this talk last year. It was controversial and confusing to a lot of people. And the great news is that there's even more data this year that will make things even more controversial and confusing. So here we go. I'm going to talk about what is a carrier and what that means to people who are Alpha-1 carriers in terms of their own personal risks of lung disease, liver disease, things like that. One thing that's new is I got a wonderful email with a picture that someone took of a truck that said AAT carriers on it. So I'm going to see what happens when there we go. Now, one of the things that was available last year was this editorial written by me and many of the people on the Medical and Scientific Advisory Committee of the Alpha-1 Foundation in reaction to the fact that drug makers, augmentation therapy makers, were promoting the use of augmentation therapy in MZ individuals with lung disease, arguing that since their package inserts said that they were indicated in the treatment of patients who were alpha-1 antitrypsin deficient and had lung disease, that anyone whose blood level was below the normal range was obviously deficient and therefore should be treated with Alpha-1 augmentation therapy. And this article took a very strong stance saying that there was currently no evidence that people with an MZ deficiency of Alpha-1, and certainly no evidence for MS deficiency, should be receiving augmentation therapy. And so I'm going to help you see why this article was published and widely distributed, and also point out reasons that it may not be entirely correct. But no matter what I talk about today, the fact is that we can't back up any of these things based on observational evidence. There has never been a study of patients who are carriers of a single gene of Alpha-1 to see whether augmentation therapy does or does not work. As you know, there's never been a randomized placebo-controlled trial of people who have ZZ alpha-1 antitrypsin deficiency to absolutely document that it's beneficial. So this is one step removed from that. But let's talk about what the issues are on both sides. And I'm happy to answer any questions at the end. One thing that's changed in the last year is this article that came out in January. It's from a very reputable lab, Jerry McIlvaney in Dublin, Ireland, who is a very well-respected researcher. And he looked at the risk to individuals who are carriers of a single abnormal gene in terms of their risk of lung disease compared to the general population. And he basically found what we had known from previous summary articles, especially one by Ed Silverman, that basically showed that individuals who are MZ and have never smoked, when compared to individuals who are MM, normal, and have never smoked, that those two populations are virtually indistinguishable in terms of the risk of lung disease. There may be a very slight increased risk of lung disease in the MZ population, but not enough difference to measure accurately. So, and as these previous studies have shown, and Jerry McIlvaney's study showed even in greater detail, if you compare normal individuals who smoke, with MZ individuals who smoke, that smoking MZ patients are 5 times as likely to get COPD, lung disease, from smoking as individuals who had normal Alpha-1. The previous studies had only shown about a 2.5-fold increased risk in smokers. This study, which is somewhat better done, and the results are more specific, shows that that risk of cigarette smoking causing lung disease in MZs is much higher than in the general population. So if I were to stop the talk there, the logical conclusion is to say that MZ patients should never smoke, and that the treatment of MZ patients who did get lung disease from smoking is smoking cessation. Period. Thank you very much. On to the next, to the festivities of the evening. But it's clearly a somewhat more complicated picture than that. In the end, I'll give you a kind of a spoiler. I'm going to come back to coming down on the fact that that's really the story of MZ individuals with lung disease. The prevention is smoking prevention. The treatment is smoking cessation. But I am going to have a few more caveats and talk about things that we don't yet understand about carriers. So let's go on and talk about genetics, just to kind of get things going. First, here's a quick course in genetics. We all know from high school biology or whatever that there's dominant genes and there's recessive genes. For example, a good example that's always given is brown eyes and blue eyes. The brown eye gene is dominant and the blue eye gene is recessive. What does that mean? If you have 2 parents who have brown eyes but are carriers for the blue eye gene, in other words, they have one blue eye gene, one brown eye gene, they will have brown eyes because brown is dominant. Their kids, on the other hand, can inherit a brown eye gene from each parent, in which case they have brown eyes. They could inherit a blue eye gene from each parent, in which case they will have blue eyes. Or they can inherit one brown eye gene from one parent and one blue eye gene from the other parent and have brown eyes because brown is dominant. Both parents in this case are carriers of the blue eye gene. There are people that you've probably seen who have one blue eye and one brown eye. Don't confuse that. That's called mosaicism. That's something that happens during embryonic development where genes get mixed up a little. So brown eyes are dominant and blue eyes are a carrier. A carrier is a recessive gene that only expresses itself in the presence of another recessive gene. So the real definition of a carrier, a person who carries a single gene for a recessive trait. That trait does not affect the carrier in any way, but can be passed on to their offspring. And that trait does not affect an individual unless combined with its companion recessive gene through inheritance. So is having a Z gene with an M gene a dominant and recessive trait? Is an MZ individual a carrier of the Z gene? The simple answer is no. An MZ has a lower than normal level of alpha-1 antitrypsin in the blood. Therefore, that carrier is actually affected by the gene. An MZ has a greater risk of lung disease than someone who's MM. An MZ probably has a greater risk of liver disease than an MM. So what should we call an MZ? We call them a heterozygote. That's the definition. And having said all of that and convinced you that carriers are not carriers, who wants to say heterozygote over and over again in a presentation? I'm going to call them carriers, but just know I'm using that word incorrectly. In fact, alpha-1 antitrypsin deficiency is called a codominant expression. Each gene expresses itself equally. So you have a normal level up here. If you have two M genes, two Z genes gives you this level, and an MZ has a level halfway between that. They each express their own characteristics. So what does it mean to be an alpha-1 carrier by our current incorrect definition? We'll be discussing MZs because most would agree, most physicians at least would agree that MS individuals have little or no additional risk of disease. They can obviously create severely deficient individuals by having the misfortune of marrying and actually having sex with someone that has a Z gene and wind up with an SZ offspring, because SZ is considered one of the severely deficient genotypes. We must acknowledge that people get unexplained liver or lung disease who have perfectly normal alpha-1 genotypes. There is something called cryptogenic cirrhosis, which means cryptogenic is just a fancy way of saying we don't know what the hell caused this liver disease. So cryptogenic liver disease. There are people who get COPD who have never smoked cigarettes. There are people who get emphysema who have never had, who don't have alpha-1 antitrypsin deficiency and have never smoked cigarettes. There is congenital emphysema in the newborn. Things along those lines. I get a lot of calls from parents who've just had their kid identified as having congenital emphysema, and they said, and my doctor says they don't have alpha-1 antitrypsin deficiency, and I say, absolutely correct. That's usually never associated with having alpha-1 antitrypsin deficiency. I made the mistake of putting all this fancy animation in, so it takes a long time for the slides to change. What do we know about MZs? We know that there's an increased risk of lung and liver disease in carriers of the Z gene. The question is, how much of an increased risk and under what circumstances? Increased risk is very small compared to severe alpha-1 antitrypsin deficiency. Increased risk of lung disease is seen pretty much only in smokers. No increased risk of lung disease has been identified in non-smokers. And I have to say that no is probably a slight exaggeration, and I'll tell you why towards the end of this talk. Many assume similar risk factors are necessary to reveal liver disease in MZs. In other words, it's not enough to have MZ as a cause of liver disease. If you have liver disease in your MZ, it usually means something else has happened to your liver in addition. What does this mean for an individual who happens to be MZ? It means that people with normal alpha-1 protein, MM, who smoke have about a 1 in 5 chance of developing COPD. That's well known. 20 to 25% of heavy smokers will get COPD. People who are carriers of alpha-1 who smoke have nearly 100% chance of getting getting lung disease from their carrier status. You'll see that this bar graph I put next to it is one I didn't change when Jerry McIlvaney's article came out, because the old article said that the risk was about double that of a MM patient who smoked. Now it's 5 times that, so 5 times 20% is 100%. People who don't smoke have less than a 1 in 15 chance of developing COPD, whether they are MM or MZ. But that also means that 1 in 15 people can get COPD regardless of their alpha-1 status, whether they're normal, MZ, MS, whatever. The most important treatment for MZs with lung disease is avoiding cigarette smoke and other risk factors that we know are roughly equivalent to cigarette smoke, like occupational exposures to dust and fumes, frequent lung infections, things like that, things that upset the balance of proteases that destroy lung and alpha-1 that protects the lungs. The most important advice to a newly identified MZ individual, especially a kid that you know who's MZ, is never smoke a cigarette and break off friendship with all your friends who smoke. Presumably, other identified risk factors for lung disease are also magnified in the MZ population, like an MZ who might work in a dusty or a fumy environment. And similar recommendations apply to reduction of risk factors for liver disease. For instance, we would recommend an MZ individual get immunized against hepatitis because we know the combination of an abnormal alpha-1 gene plus hepatitis seems to lead to a worse case of hepatitis. There's the interaction that makes someone have a worse problem in their liver, for instance, just by virtue of the fact that there is misfolded protein in the liver cells of people who are ZZ or MZ. I should remember to click this earlier. So the big question that is on everyone's mind, especially with the push from some companies, in fact, almost all companies, to treat these MZ patients, is should MZ patients with lung disease receive augmentation therapy? Well, the easy answer, based on the information I just told you, is no. Unfortunately, it's more complicated than that. We really don't have enough information yet to make such a definitive recommendation. There may be some presumably rare individuals who will benefit from augmentation therapy, but it's likely that most will not. And remember, there are millions of people in the country who are carriers of a single abnormal gene, 23 million if you include MZs and MSs. And there aren't that many patients that have COPD in the country. So it isn't an overwhelming issue in the US population. It's likely most of these will not, as long as they eliminate risk factors from their life. And why have so many MZ patients been started on augmentation therapy then, if that's the case, if what I'm saying is true? And in fact, in recent years, the majority of patients being started on augmentation therapy have been MZ, because there's so many more of them than there are ZZ patients. Docs have little else to offer a patient with COPD. A doc that's following someone with emphysema, all they can do is give you your Advair and your Spiriva and treat exacerbations, and there's no pill a doctor has that they can say, take this and in 6 months your emphysema will be gone. It's a very frustrating disease to treat, almost as frustrating a disease as having the disease. And doctors want to help their patients. And if someone gives them the suggestion that maybe giving this expensive intravenous therapy will perhaps keep a patient healthy, at least it's something they can try. The question is, how do you know if it works or not as you're spending $150,000 a year, or your insurance company is, or we all are, on this therapy? Many doctors are ignorant about the data regarding MZ deficiency. They say, well, gee, the normal range is 100 to 200. This person's level is 90. They must be affected by that. Let me give them augmentation therapy. Plasma product companies or their sales reps want to make money by treating this much larger population of patients. It's a money trove for them compared to the number of alpha-1 patients with ZZ deficiency or SZ deficiency or Z null or any of those other much rarer severely deficient genotypes. And so there's a much larger payoff if those patients get treated. That's a cynical view. Lots of people in all of these companies absolutely agree with what I'm saying and don't promote that. I'm happy to answer your question.
Sandy, do you recommend that in cases where an MZ has
I'm actually going to talk about levels in a second, because that's one of the new confounding factors. One thing to keep in mind when you're considering this issue is that the goal of augmentation therapy in ZZ patients is to bring them to the level of MZ patients. So basically, we're turning ZZ patients into MZ patients by treating them with augmentation therapy. So it kind of belies the fact that people are recommending treating MZ patients when this is the level that has clearly been identified as a level that's protective in patients that are severely deficient. So let's talk a little about what's new. One of the things that's new is that we're identifying some MZ patients who don't have a level of 90 with a normal of 100. You may notice that your normal ranges are different. Every lab finds its own normal ranges. And don't forget, they define a normal range by taking a whole group of people and testing them for Alpha-1, who presumably are healthy people, and then finding what the range of values, 93% of those people fall into. But one in 14 or 15 people in the US has an abnormal gene for Alpha-1, so I can promise you that that large group of normal individuals that they included in the normal range was a carrier of Alpha-1. But just the same, every lab calculates its own normal range. In some, the lower end of normal is 90, and some, the lower end of normal is 75, and some it's 100. And so people with MZ deficiency often have levels that are below that. They can be above into the normal range, below it. Don't forget, Alpha-1 levels change from day to day in everyone, even people who are ZZ. Alpha-1 is one of the acute phase reactants. The liver puts out more or less depending on the inflammatory state of your body, and it's one of the reasons we don't recommend doing a lot of Alpha-1 levels on people, whether or not they're on augmentation therapy. And most MZ patients fall in the range of 60 at the lowest up to into the normal range at the highest. But there are some MZ patients that we found whose levels are considerably lower. They are really MZ, they haven't been misdiagnosed, but they have low levels. And we've just begun to get an indication of why that might be, because there are some newer forms of genetic testing that don't only look at the gene itself, but they look at companion genes that affect how many times and how fast that gene is copied to make protein. And there's a paper that's going to be published by Fred Coopers in the Philadelphia area, where he's accumulated a number of MZ patients with very low levels, and they are finding that while the sequencing of the M and the Z genes is exactly what's expected for MZ, that they have abnormalities in another area, distant area of the DNA that controls, it's called the promoter region, that determines how many times the gene is copied or how fast the gene is copied when making proteins. And so it could be that not all MZs are the same. So that certainly adds a wrinkle to this, but it's not a subtle wrinkle. Those patients, instead of having levels that are 70, 80, 90, 100, have levels that are 20 or 30. And so there's a clear distinction, at least as far as we can tell, between those individuals that have this unusual kind of heterozygote MZ deficiency compared to the other 99.9% of MZs that have much higher levels. So that and Jerry McIlvaney's paper have changed already since I gave this talk last year. And it's a kind of a situation where I'd say stay tuned as we learn more about this. So let's take a question that some of you might ask if given the opportunity. I'm an MZ. Why do I feel so much better since I started augmentation therapy? Well, even ZZ patients aren't expected to feel better from being on augmentation therapy. Augmentation therapy is designed to slow or halt the progression of lung disease, not to make you breathe better, not to make you feel better. Now, alpha-1 antitrypsin protein is one of the body's main anti-inflammatory proteins, and so there are reasons you could think of to explain why someone might feel better once their levels came up. But in general, that's not expected. A second possible explanation for why someone feels better is a placebo effect. And it's well documented, number one, that placebo effects are real, that people feel better when given a sugar pill for any of a number of conditions, from severe pain to infections. It's well documented that people given a placebo pill versus people given a placebo injection or infusion, the injection or infusion is perceived as having a much better effect than the pill. And if you spend a lot of money for the sugar pill or the infusion, the placebo effect is even heightened more greatly. And I'm not saying that to be humorous. These are actually scientific studies that have been done that have shown that these things magnify the placebo effect. It's a real effect. Patients can use that effect to help them through episodes of pain and things like that. And the placebo effect is real, and people feel better when they are getting an infusion of an expensive medication. Or you could be one of the few patients who may benefit from augmentation therapy, although there are a number of very respected Alpha-1 docs who would argue that no such MZs exist. I think we're to our last slide. And that last slide says, now's the time to tell me all the things you disagree with about what I said. Please do. I can take it. Yes? Do I think it is insignificant for an MZ to know their serum levels? I think that it's very clear that the risk of lung disease in alpha-1 patients is related to either the level of alpha-1 or the functioning of the alpha-1. And an MZ patient whose level is 20 milligrams per deciliter probably has exactly the same real risk of emphysema as someone who's ZZ with a level of 20 milligrams per deciliter. But I also would suggest that those patients are few and far between. I happen to know there's one here because they came to me and told me their levels and asked me why in the world their level was so low. And last year I would say, you probably were tested incorrectly and you're not MZ. This year I can say, we know now that there are some MZs whose levels are low. We even have an explanation for it. And I would probably consider that patient I would treat that patient the same as a ZZ individual. Oh, yes, the herbal substance that's legal in Colorado you're asking about. Go ahead.
Do you have any data on the effect of that kind of smoke?
Okay, so we make up things about marijuana smoke without a lot of real experimentation, because until things became legal, we really couldn't do studies. In fact, there's a huge number of studies in Colorado that have started up on lung disease and other issues, thanks to the legalization of marijuana that couldn't be done in the past. But we do know some things. The constituents of the smoke of marijuana were looked at primarily during the paraquat days. Some of you are not old enough to remember those days, but in the 70s, I think it was, there was a herbicide that was sprayed on Mexican marijuana fields in order to kill the marijuana and cut down on the traffic into the United States. And that herbicide was called paraquat. And cleverly, the Mexican marijuana growers, whenever a plane came across and sprayed their plants, they quickly harvested their marijuana and sent it up to the US. And paraquat causes a severe lung disease, a scarifying lung diseases like pulmonary fibrosis. And so people were analyzing the smoke of marijuana for that. And basically, marijuana smoke doesn't have exactly the same constituents as tobacco, but it has a lot of the constituents that we know are injurious to the lung. It has a lot of the oxidants. It has some of the carcinogenic agents, not the wide spectrum of carcinogenic agents that cigarettes do. And many of these agents are at much higher quantity per puff than in cigarettes. And the saving grace of marijuana is that most people don't smoke 40 to 60 joints a day, the way a heavy smoker smokes cigarettes. You know, 2 to 3 packs is 40 to 60, or no, more than that. It's 40 to 60 cigarettes a day. And also, marijuana can be delivered by vaporizers, which don't burn the vegetation, and can be eaten. And so I'm not advocating any of those things, but there are ways to protect yourself from the effects of inhaled smoke. And inhaled smoke is a bad thing for any Alpha-1 patient, no matter what the source of the smoke. Sure, you would ask that. Got one over there? Good.
Both of my kids are MC,
Congratulations.
and they're in their 30s. They know to take good care of themselves. But I'm just wondering,
How are they doing?
well, my daughter just finished a half marathon and did really well.
So her 2 grown children who are MZ.
But they just found out when I found out 3 years ago. So I just wonder about any experience you've had or recommendations about communicating with young people who are in that sort of time frame when they experiment a lot with alcohol, drugs, smoking. It just seems like, okay, most of us, we know what it does. We know what it's done to our lungs or liver, or we're wiser now. But what about kids who feel invulnerable?
Yeah.
And either they're going to freak out and think they're on death's doorstep, or they're going to think, well, what the hell, I can do this anyway.
Well, I think I tell you what I think. I think that, it's leverage. You're talking about what to do to help kids that are at risk like this enjoy a better lifestyle than most kids do during their experimentation periods and things like that. I'll tell you some things that give me hope that in fact making the diagnosis in a child is a good thing. One of the things is that we know that a lot of the time people say to us when we say one of the things we're going to do if we find someone with Alpha-1 is we're going to promote smoking prevention and cessation. And the usual answer we get back is, well, you should promote smoking prevention and cessation in everyone. Why does having Alpha-1, why should that be an action that you do that's related in some way to making the diagnosis of Alpha-1? Well, the fact is that people with Alpha-1 antitrypsin deficiency who learn about their disease have a much better quit rate, 30% versus 90%, than the general population. And I think it has to do with the fact that the gene for Alpha-1 imparts intelligence and good looks on people. And so they listen to their doctors. But what I really believe is that knowing the mechanisms for the lung destruction can be explained. You talk about the white blood cells, about the elastase, about the Alpha-1, and the fact that there are chemicals in cigarette smoke that inactivate Alpha-1 in the lung. That in fact, cigarette smoke turns healthy individuals into severely deficient people with a single cigarette exposure to their lungs. The good news for people who don't have Alpha-1 antitrypsin deficiency is the liver can replace that Alpha-1 pretty quickly.
Sandy, I just have a quick follow-up. Given the statistic that about 1 in 14 or 1 in 15 Americans carries a Z or an S allele, then that means there are an awful lot of young people wandering around. And why should we not have
Burst
a
screen.
huge national campaign against smoking. Let's put tobacco out of business.
Yes. I thought you were going to advocate for newborn screening, which is something that we are advocating for.
Okay, thank you, Sandy.
Wait, you said 3. What does that mean?
I know, but I'm being told we need to vacate the room.
Okay. Thank you.
That's okay.